Doctora, nosotros no intervenimos con voz ni nada en el seminario. Puedo hacer la invitación a través del chat, pero nosotros no intervenimos dentro de la sesión. Usted como coordinadora hace el anuncio.
Prueba del canal español, probando, 1, 2, 3. ¿Me escuchan correctamente en el canal español? Perfecto, gracias.
Adelante, doctora, ya podemos iniciar.
Bueno, buenos días a todos. Tenemos el honor de darles la bienvenida al curso de actualización en epidemiología, actividad conjunta de ERA-EDTA y SLAN. En primer lugar, quiero agradecer a la organización del Congreso por invitarme a coordinar esta actividad con la que estamos comenzando el precongreso en el día de hoy. Con el grupo de docentes del registro de la Asociación Renal Europea y de la Asociación Europea de Diálisis y Trasplante, ERA-EDTA, compuesto por la profesora Kitty Jagger y los doctores Bian de Stil, Mick Snaye y Siad Massi, los tres primeros de los Países Bajos y el doctor Massi de Francia, nos une una historia que comenzó en el año 2007, cuando organizamos con la doctora Cusumano, que en ese momento era la coordinadora del Registro Latinoamericano de Diálisis y Trasplante Renal, el primer curso de introducción a la epidemiología en la ciudad de Buenos Aires, que increíblemente nos recibió nevando en esa oportunidad. Esa instancia fue algo así como una cruzada, una patriada, como decimos nosotros, porque se organizó prácticamente.
With us because it was organized practically.
Significó un éxito de asistencia y de aprendizaje, y siempre decimos que fue un punto de inflexión en la historia de nuestro registro. Ese fue el comienzo de una relación de generosa cooperación y de amistad con el registro europeo, que se consolidó luego en 2009 y 2012 con la repetición de los cursos en el Congreso SLAN de México y Cartagena, ya con apoyo orgánico de nuestra sociedad, y luego con la institución de una beca de registros financiada por SLAN y ERA-EDTA, que usufructuaron las doctoras Rosario Luzardo y Laura Cereta en los años 2015 y 2016 respectivamente. Con ellos hemos compartido también la realización de muchos trabajos, publicaciones múltiples y de otras actividades vinculadas a registros. Nos hemos comunicado continuamente, los hemos consultado reiteradamente y participamos además con la doctora Kitty Jagger y el doctor Rosa Díez por el registro latinoamericano en el proyecto SHARER de la Sociedad Internacional de Nefrología.
Doctora, ¿podría prender la cámara, por favor?
Sí, pero es que no prendía. No lo puedo prender. Está apagada por ustedes.
Continúe, doctora, muchas gracias.
Como les decía entonces, estamos participando en ese proyecto de compartir experiencias en los registros renales, junto con el doctor Rosa Díez y la profesora Jagger. Este curso comenzó a planificarse en el año 2019, cuando pensábamos que este sería un congreso que se realizaría en la ciudad de Panamá con la presencia de todos. La realidad del acontecer inesperado de la pandemia cambió totalmente nuestros planes. Pero más allá de la adversidad, nos encuentra nuevamente juntos, dispuestos a seguir aprendiendo con ellos y por sobre todo a seguir estrechando el vínculo de amistad que hemos fortalecido en estos casi 14 años, en el entendido de que el conocimiento no es patrimonio exclusivo de nadie y que al compartirlo no solamente lo multiplicamos y potenciamos, sino que por sobre todo forjamos vínculos indestructibles de solidaridad y de afecto, herramientas que en este momento más que nunca han demostrado ser imprescindibles. Les doy entonces la bienvenida a esta jornada que sin duda será memorable para todos. Gracias.
Good morning, everyone. I think that I'm supposed to start my presentation now.
Yes.
Okay, thank you. Thank you, Carlota.
You can start the presentation now.
Yeah. Okay.
Doctora, ¿puedo?
So, good morning, everyone. It's my great pleasure to start off this course today with my presentation on where to look for frequent biases. I will try to speak a bit slowly because of the simultaneous translation. So my presentation is about bias, and bias is one of the errors in clinical research. Errors in clinical research can be divided into random error and systematic error or bias. And it is important that when performing a study, a researcher must attempt to reduce both sources of error. And as a reader, in interpreting a study, he or she must be aware of both sources of error and find out if and how the researchers have tried to address them. Let me first focus on random error. Random error is nothing else than variability in the data. And that variability can be due to either real differences in measurements of participants in a study. And secondly, it may be due to imprecision of measurements due to imprecise measurement instruments. And as random errors are unpredictable, they may affect reproducibility. So the next time you do a study, the results can be different. Now, let's focus here. I hope you can see my pointer. Let's focus here on the so-called source population. The source population is the whole group of people that you would like to study. And if you have many people, you will find a so-called real average, the real average in the source population of all the measurements that you do. Now, if you take a sample, then what happens if you have a very small sample of only 3 measurements here, then it may be that the average in that population, in that study population, is far away from the real average that is supposed to be here in the middle. And when you increase your study population, that average will go to the middle. So it will much more reflect the real average in the source population. Now, what are the solutions to reduce random error and find the correct average in the source population? Either you can do that by increasing the sample size, so not measuring 3 people, but a lot of them. And secondly, you can measure exposures and outcomes more accurately by using more precise instruments. In contrast to this, there is systematic error, also called bias. In that case, the measurement is systematically wrong. Imagine that in a restaurant on a particular evening, the cook will add far too much salt in all the meals. That will result in an increase of blood pressure of the restaurant guests. Now, you could say that on that particular evening, there is a systematic error because the measurement of blood pressure is systematically wrong. It does not represent the blood pressure in all the guests on different evenings, only for this particular evening when this systematic error was made. Now, the problem with bias is that it cannot be decreased with a large sample size. This is shown on this slide. Here you have the sample size, here you have the size of the error. And when you increase the sample size and it's random error, you will see that with increasing sample size, random error decreases. With systematic error, however, it will not decrease. The bias will stay exactly the same, now, no matter how big the sample size. Now, there are three main types of bias. A study may be biased depending on how the study subjects were selected. We call this selection bias. It can also be biased because of the way the study variables were measured. That's called information bias. And finally, a study can be biased because of the way the association between an exposure and an outcome was determined. And that is called confounding. Today, I will discuss only the first two types, selection bias and information bias. Selection bias stems from errors in the selection procedure of study participants or from factors that affect study participation. And the reason is that the relationship between an exposure and an outcome may differ in those who participate in the study and those who don't. Today, I will explain a bit about six types of selection bias. The first is sampling bias. As I referred to in the first slide, this is the source population. Imagine that if you would like to do a study in the dialysis patients, this would be all dialysis patients in the whole world. But of course, you cannot do a study in all dialysis patients in the whole world. You need to take a sample, either of your own center or maybe in a multi-center study, but the number of people in that study is much, much lower than in the source population. In order to avoid sampling bias, you need to make sure that the sample is representative. It needs to be people who are of the same age, for example, who have the same sex distribution as in the source population. So, where possible, a sample should be based on available information on potential respondents. Imagine that you would like to do a study of CKD prevalence. When you want to study that, you can use census data or electoral rolls to select your study participants to obtain random samples reflecting the age and sex distribution in the general population. Now, in many of these studies, sampling methods are not reported, and that leaves you a bit in the dark about the representativeness of the sample. But even if the sample itself has been taken at random, there's still the possibility of response bias due to non-response of those included in the sample. You can imagine that if you have selected a sample of 100 people, then it may be that half of them will refuse to participate in your study. So then you are suffering from response bias. Sampling bias is typically found, I think, in all study designs. It may be cross-sectional studies and cohort studies where people use non-representative samples of the source population, and especially those with low response rates, as I just explained. Low response rates very often occur in, for example, surveys. Then you may already be very happy if your response rate is 50%, because in most surveys it's much lower. The consequences of sampling bias are over or underestimation of frequencies. So, for example, incidence or prevalence, or the over or underestimation of effects or associations. And the way to prevent sample bias is to use state-of-the-art techniques to obtain random samples. And secondly, of course, to reduce non-response as much as possible. The second form of selection bias I would like to discuss is so-called confounding by indication. This is a type of bias that occurs in observational studies and that is induced by physicians and due to unmeasured confounders. Let me give you an example. Suppose that you would like to compare the patient survival in patients starting hemodialysis and those starting peritoneal dialysis. But of course, as a doctor, he or she will think, in case of a particular patient, that this patient is better suitable for hemodialysis, for example, and then he will give that patient, or he will advise that patient, hemodialysis. In other cases, he or she may think that peritoneal dialysis is a much better option. And for that reason, given all the characteristics of that particular patient, the doctor will advise peritoneal dialysis. Now, if you want to compare patient survival between those two treatment modalities, ideally, what you would like to have is that the only difference between the two compared groups is the treatment modality. But because of this indication, those two groups will not be different. There will be a lot of measured and unmeasured confounders that are different between those starting hemodialysis and those starting peritoneal dialysis. Now, the best way to take away the effect of confounding by indication is randomization. Why is that? Because randomization increases the chance that both known and unknown confounders will be balanced across treatment groups, and that any remaining differences between the groups are due to chance and not the result of the choice of the doctor. Now, many of you will say, okay, but you can adjust for differences in statistical analyses. But the problem is that statistical analysis does not allow correction for unknown confounders. It only allows correction for known confounders, and for that reason, randomization is much better. Confounding by indication is typically found in non-randomized intervention studies. So when researchers want to do an intervention, like for example, a treatment. And non-randomized intervention studies are, for example, cohort studies or case control studies or cross-sectional studies. And if you don't have randomization, the comparison of outcomes between the two interventions or treatments will be unfair due to those unmeasured confounders. And the results of the study cannot be used for medical decision making. And the only way that you can prevent confounding by indication is by using randomization. The third bias I would like to discuss is the bias that results from the fact that investigators use prevalent patients, so existing patients, instead of new patients, incident patients. Let's have a look at an example, a hypothetical example of a study in which the doctors would like to investigate the patients with severe emphysema, and they would like to compare the mortality in those who continued smoking and those who quitted smoking. Now, on the left, what you can see here is an incident cohort. And with incident, I mean that in these patients, the diagnosis had just been made. These are new patients. Those are 20 of them. And here, the dark bars indicate the patients that continued smoking, whereas the light bars indicate the patients that quitted smoking. And here on the right, you can see the deaths. And sorry, here you can see the deaths, and here you can see the number of patient years. So these are the patients who continued smoking, and in green are the patients who quitted smoking. Now, in the patients who continued smoking, there were 10 deaths in 14 patient years. And in the patients who quitted smoking, there were 10 deaths in 26.5 patient years. If you make a calculation here, you will see that a mortality rate ratio will be 1.89, meaning that those who continued smoking had a higher risk of death, an 89% higher risk of death than those who quitted smoking. Now, suppose that other investigators didn't want to start with new patients, but they said, okay, but we will start looking exactly 1 year after diagnosis. So that is a so-called prevalent cohort. And in that prevalent cohort, there were 14 patients left from the 20 that originally started. Again, we did the same here. There were the deaths. Those are the patient years in those who continued, and those are the patient years in those who quitted. And if you then calculate the mortality rate ratio, what happens is that in the ones who continued, there were 6 deaths in 5 patient years versus 8 deaths in 17 patient years in those who quitted. That makes a mortality rate ratio of 2.55. And there, this biased mortality rate ratio indicates that instead of an increase in mortality of 89%, there's an increase of mortality of 155%. So this mortality rate ratio is biased. It's an overestimation of the effect of continuation of smoking. Now, where can you find this incidence prevalence bias, also called survivor bias, because prevalent patients are so-called survivors? It's of course seen in all the study designs using prevalent patients. So that means cross-sectional studies, because cross-sectional studies use all patients, those who start early, those who are new, those who are older. So that's cross-sectional studies. And in cohort studies, not using incident patients. And also, of course, in case control studies. The consequences are an over or underestimation of the effect estimates. And the problem here is that you can never predict the direction of the bias. It can go both ways. Either you can have an overestimation of the effect or an underestimation. Then there's so-called attrition bias. Maybe I first need to explain what attrition is. Attrition is the loss of participants during a study because of patients may withdraw, or they may drop out, or there may be protocol deviations. And the problem of attrition bias is caused by the fact that people leaving a study may be systematically different from those who continue. Let me give you an example. Suppose that investigators would like to study the effect of prescription of a healthy diet, the effect of this diet on hypertension, and they want to compare this to standard care. Now, the problem is that in the group that got prescribed the healthy diet, those who have problems with compliance, they may drop out. And then the more health conscious patients in the study are left behind. And because of that, there may be a potential overestimation of the effect of healthy diet on the occurrence of hypertension. This is found typically in longitudinal studies. It may be in RCTs. It may be in prospective cohort studies. So all the studies in which the follow-up is a bit longer, so to say. And the consequences of attrition bias are over or underestimation of effects. You never know. Then there is so-called collider stratification bias. This one may be a bit more difficult to understand. So I first need to tell you what a collider is. A collider is a variable that is directly affected by two or more other variables. And in the association between an exposure and an outcome, the so-called collider stratification bias may be induced by controlling for a collider in the data analysis. And you can control for a collider by either restriction to a subgroup or by statistical adjustment for that collider. Now, the example that I can use here, I think is a quite famous example. It is the so-called effect of the so-called obesity paradox. That's the effect of obesity on mortality in end-stage kidney disease patients. What you can see here is a so-called directed acyclic graph. Now, in the general population, if we study the relationship between obesity and mortality, we know that the more obesity, the higher the mortality. That is what we all expect. Now, and even if that relationship is adjusted for measured confoundeds. Now, if we only study end-stage kidney disease patients, that characteristic of patients may act as a so-called collider. Why? Because obesity affects the incidence of end-stage kidney disease. But there are also many unmeasured factors that we don't know of, that will affect the occurrence of end-stage kidney disease. And these unmeasured factors can also affect mortality. Now, as I said here, end-stage kidney disease is a collider. And a collider induces a non-causal association between the unmeasured risk factors and obesity. And for that reason, we can measure a seemingly protective effect of obesity on mortality in end-stage kidney disease patients. And that is what we call the obesity paradox. And this so-called collider stratification bias is one of the explanations why we find that obesity protects against mortality in end-stage kidney disease. Collider stratification is typically found especially in Coord studies, where they study groups of patients that are selected on the basis of a collider. We call that restriction. If you study only a specific group, then you call that restriction. Or it can also happen because you adjust for a collider. And the point is that this bias may even add to incidence prevalence bias, as by selecting prevalent patients, one restricts on the collider of having survived. So if in studies using prevalent patients, you will not only have incidence prevalence bias, but also collider stratification bias. And then there is publication bias. In contrast to all other types of bias, publication bias is not the consequence of flaws in the study design or study content. Sorry. It's been described as any tendency on the part of investigators or editors to fail to publish results on the basis of the direction or strengths of the study findings. And here you may think, for example, of studies that have negative results. So investigators don't find a difference between one group and another. And then what may happen is that either the investigators themselves, that decide that this paper is not worth of submission, because they are afraid that the editors will refuse the paper. They will reject it because of the lack of difference between the two groups. And as a result, the published papers may not be a representative sample of all the studies that were performed. So it originates during the entire study process. When study results are generated, the investigators may choose which of them to include in a manuscript, and secondly, whether or not to submit the manuscript. And then the editors and the reviewers come in, and then they decide whether or not to accept the paper for publication. Now, the problem is that not all relevant studies using sound research methodology are accepted for publication. And as a consequence, meta-analyses using those studies may overestimate treatment effects and risk factor association. And that, in the end, will lead to inappropriate clinical decision-making and health policy decision-making. Okay, sorry for that. Usually, in the case of bias, you cannot detect it. You need to think about it, and given the study design and the analysis, you may speculate that some types of bias in a study may occur. But it's different with publication bias. Publication bias can sometimes be detected by a funnel plot. And you can see a funnel plot here on the left. What it shows is, this is the study size here on the y-axis. And here on the x-axis, there's the effect estimate. And here there may be a reduction of the risk, or here there may be an increase in risk. And the effect is then plotted against a measure of the study size. So here are the largest studies. Then there's a vertical line here that is used in order to detect symmetry or asymmetry. And in this particular case, the larger dots represent larger studies. And normally, without publication bias, these plots are shaped like a funnel. And by a funnel, I mean that here you would find a similar number of studies as you would find on this side. But in this case, the funnel is asymmetric. The right lower side seems emptier. The small studies are missing, pointing to publication bias. And publication bias may affect all study designs. Then the second type of bias is information bias. This is caused by errors in the measurement, collection, or interpretation of the exposure variable, of the outcome variable, or of both. And in studies using categories for exposure and outcome, it may cause that individuals may be placed in the incorrect category. And that is what we in epidemiology call misclassification. And this misclassification can be non-differential or differential. Exposure misclassification is non-differential if it is unrelated to the presence or occurrence of disease, so unrelated to the outcome. Otherwise, it is differential. Let me give you an example. Here, the investigators wanted to do a study investigating the intake of high caloric beverages with the occurrence of cerebrovascular accident. So, when all the intakes and the outcomes were correctly classified, this was the distribution of cases and controls in patients who had a high intake and a low intake. And if you then calculate the odds ratio, you will arrive at 5.0, meaning that individuals having a high intake of high caloric beverages, they have a 5 times as higher risk of cerebrovascular accident. Now, if there would be non-differential misclassification, and in this case, it shows that 20% was considered to have high intake instead of low intake, and vice versa, 20% was considered to have low intake instead of high intake. If you do that, or if this happens, these are the numbers. So these numbers are different from the numbers that happened if the cases were correctly classified. And then what happens is that the odds ratio is decreased by 60%. Now it's only 2, meaning that those with a high intake of high caloric beverage had doubled the risk of a cerebrovascular accident. And the point with non-differential misclassification is that it will always dilute a true effect. So it will bias, what we call as epidemiologists, it will bias towards the null. So 5 becomes 2 and the risk seems much lower. There are different types of information type bias. I will discuss during this lecture 4 types. First of all, there's recall bias. And recall bias, so it has to do with memory. And it is caused by differences in the accuracy or completeness of recall to memory of past events or experiences only after people know about the outcomes. This may lead to misclassification of the exposure. A very famous example is the one on birth defects. Suppose that you are a mother and your baby will be born and your baby has a birth defect. Then you will be thinking all over again, what may have caused this defect? And of course, other mothers with healthy babies, they will not do this. Their memory will be less complete. And this may lead to a misclassification of exposure. So those who have those mothers with a baby with a birth defect will think of many more exposures than those with healthy babies. So there will be a bias in the relationship between a particular exposure and a birth defect. And we call this maternal recall bias. There are quite some examples in nephrology. For example, people that have glomerulonephritis, they may be asked about possible toxic exposures, and they may remember better than those without glomerulonephritis, simply because they will have thought about this potential exposure a lot better than those without glomerulonephritis. And also women with acute pyelonephritis, they may be asked about frequent urinary tract infections in their mother, because the researcher considers genetic factors. Unlike other people, they may have discussed such infections with their mother, and therefore they will know better if their mother indeed suffered from such frequent infections. This type of bias is typically found in studies that use self-reporting. And then you may think of case control studies and retrospective cohort studies. And one of the ways to prevent recall bias is not to ask patients directly, but to make use of hospital records in order to verify individuals' recall to memory. And also, another possibility is to make use of controls suffering from another disease who may have searched their memory in a similarly thorough way. Then there's interviewer bias. I'm sure you will have heard about this. It's a systematic error that is due to interviewers' subconscious gathering of selective data, or their influence on subject response. Suppose that you are an interviewer and you are really convinced about a particular relationship between an exposure and an outcome. What you will then do is ask leading questions. But also you may influence respondents, and respondents may have the inclination to give you the answers that you as an interviewer would like to hear. We call this social desirability bias. And thirdly, physicians or investigators may increase recall bias by more intensive questioning of cases with the disease on factors known to be associated with disease. That's called exposure suspicion bias. For example, people with glomerulonephritis, you may ask them more intensively, you may question them more intensively, for example, on their potential contacts with heavy metals. This type of bias is typically found in all studies that make use of interviews, and it can be reduced by standardization of the interview. And that means that you will give the interviewers less room for also asking questions in a particular way. You will more or less phrase the study questions in a very exact manner. And secondly, it can be reduced by blinding the interviewer to the outcome or disease status of the respondents, so that the interviewer doesn't know whether this particular patient indeed suffers from glomerulonephritis or not. Then there's observer bias that is defined as a systematic difference between a true value and an observed value due to observer variation. And I'm sure that many of you know the historical example of blood pressure readings using analog sphygmomanometers. I'm not sure about your age, but when I was studying as a doctor, I can remember that when you try to measure blood pressure using this kind of instruments, you sometimes need to choose whether this patient has a systolic blood pressure of 170 or 175. And then the point is here that doctors tend to route down blood pressure readings in patients of whom they know they are on hypertensive medication, and to round them up in patients who are not. So subjective judgment here plays an important role. And if such differences in judgment are systematic, they may induce bias. And observer bias may play a role in reporting, in evaluation and processing of data, as well as in the statistical analysis. If the analyst knows the status of the patient, knows their exposure, then he or she may be influenced and analyze the data in a particular way. It's typically found in RCTs and observational studies. It can lead to over or underestimation of treatment effects. And the way to prevent it is to blind clinicians, patients, and statisticians to treatment so that they don't know whether or not a patient received a particular treatment. And this is the last one, lead time bias. Lead time bias can lead to an apparent increase in survival resulting from disease detection at an earlier stage. Let's have a look at the figure. Usually, patients are diagnosed when they have symptoms. And then the disease is diagnosed and treatment is given, and at a particular moment, the patient will die. Let's say that this was 2017, and this was 2019, and then the survival was 2 years. But suppose that the disease was not diagnosed by symptoms, but by screening. Then you have an early diagnosis and treatment, And then the patient this might have happened in 2014. And then the patient will have survived 5 years, from 2014 to 2019. And this difference of 3 years, that is what you call lead time. Now, the point is that in reality, there may not be an actual effect on survival, but just a longer period with the diagnosis. And a very well-known example is survival comparisons between countries or regions with and without screening programs. Those with screening programs will have a much longer survival, but that longer survival, it is not real. It is biased by lead time bias. Now, there are a number of nephrology examples. For example, those comparing policies of early and late start of dialysis. You may say that when patients start dialysis at a higher eGFR without severe signs and symptoms, their survival is compared to those starting dialysis at a lower eGFR with severe uremic signs and symptoms. Then this comparison may suffer from lead time bias, favoring those with an early start. It just seems as if these people starting early really live longer. This type of bias is typically found in cohort studies comparing survival times between screened subjects and those diagnosed on the basis of symptoms, and studies comparing survival between patients in different stages of disease. When I summarize my talk, I think I can say that I tried to discuss biases in relation to study designs where they frequently occur. And again, I would like to repeat that researchers should really try very hard to prevent bias in study design, in study conduct, and in the reporting of study results. Now, even if people do this, we can state that no study is completely free from bias, because you can never prevent all bias. And if you think that you have, as a researcher, you haven't succeeded in preventing all the biases, you should mention them in the discussion, because it's important for readers to better interpret your results. And finally, reviewers and readers must look for biases and to see if the study findings might be due to the way the study was designed or carried out. And in this way, they can just judge if the presented findings are really reflecting the truth or are biased. Thank you very much.
Following, we'll have Dr. Jaeger's Q&A. Please remember to turn on your camera so the participants may see you.
It says I cannot start my video because the host has stopped it. So maybe you should enable me to share my video.
Muchas gracias, Kitty, por esta excelente charla. Yo también estoy tratando de encender la cámara, pero no lo he podido hacer. Tenemos, para continuar, espero que hayan disfrutado todos de esta charla. Quiero antes que nada recordarles que todas las actividades del Congreso van a permanecer en el sitio para poder ser vistas para los inscriptos durante los próximos 3 meses. Y bueno, ahora vamos a dar paso a 5 minutos de preguntas. Ya tenemos una acá. La doctora Luzardo nos pregunta ¿qué cosas son importantes en el cálculo de la muestra para evitar errores sistemáticos?
You will need to translate for me, Carlota.
Yes.
What are the important reasons in the calculation?
In the calculation of the systematic error.
Dr. Jaeger, please try once more.
I was asking Carlota if she could translate the question for me.
Yes. About what are the important things to calculate the systematic error? Do you understand me?
Yeah, I understand you. The point is that you cannot calculate a systematic error. You need to think about the study design, whether the study design was good enough to say that the results of your study are valid. And then you need to think about what was the study design, what did the investigators do to prevent all types of bias that are frequently occurring in that type of study design. So you cannot calculate bias, you need to prevent it.
La doctora lo que preguntaba es cómo se puede calcular el tamaño de la muestra para prevenir el error sistemático.
So maybe that's an important thing which I did not say with so many words. You must do everything as a researcher. You must do everything in your power to prevent bias, because you cannot correct for bias. You cannot calculate it. You cannot correct for it. Once the study is biased, you can't do anything anymore.
La doctora se refería al tamaño de la muestra, sample size.
I'm not exactly sure what the question is about the sample size. Well, sample size calculation may be, yeah. Sample size calculation is important for randomized controlled trials. It doesn't help you in the prevention of bias, because increasing the sample size will not repair bias.
Okay. Perfecto. Por favor, ¿hay alguna otra pregunta? Tenemos unos minutos más habilitados para preguntarle a la doctora Hager. Bueno, entonces podemos continuar con la conferencia de la doctora Steele, y en todo caso, si hay más preguntas, acá tenemos una pregunta, la última. Could you please explain another example of colliders?
Well, that's a very difficult question, because you really need to look at particular studies. This example of the obesity paradox is a very famous one. I think that I've been thinking about this a lot, because some of you may know that I am working for the ERA-EDTA registry. So we are doing studies in patients with end-stage kidney disease. And if you do studies in patients with end-stage kidney disease, you are already restricting to a particular group, namely patients with end-stage kidney disease. You cannot expect that in patients with end-stage kidney disease, relationship between exposure and outcomes will be the same as in a general population. And the reason is that you have restricted your group to end-stage kidney disease. So in my personal view, that is one of the reasons why many RCTs in end-stage kidney disease patients are providing negative results, because in end-stage kidney disease patients people are different. They are the ones who survived up to end-stage kidney disease. So I'm sorry that I cannot give you an example right away, but I think that in our area of research, it happens quite often.
La última pregunta. El doctor Manuel Ubillos pregunta, en los sesgos de incidencia, la inclusión de pacientes reales no reducen, pero ¿cómo determinar si realmente son datos reales?
Can you explain, can you translate, Carlota?
Bueno, entonces continuamos con la presentación de la doctora Steele, la conferencia de la doctora Steele, que va a hablar sobre los puntos de atención cuando se conduce una investigación etiológica. Adelante, doctora Steele.
Seguimos con la presentación Points of Attention when Conducting Etiological Research con Vianda Estel de Netherlands.
Thank you so much for your introduction, Maria. I will share my screen. Well, good morning, everybody. I would like to tell you something about points of attention when conducting etiological research. And actually, it's quite a challenge to tell you something about this because etiological research has so many aspects and I cannot explain everything. So I would like to go through all the steps, but I will focus on some points and not all of the points because that's not possible. Well, let's start with what is etiological research. In this kind of research, we always look for an association between an exposure and an outcome. So for instance, the association between a treatment and mortality, or the association between smoking and lung cancer. And in these associations, we are in particular interested in the causal relationship underlying the studied relationship. So the researcher would like to know the biological mechanism behind the association. So for instance, in the association between smoking and lung cancer, you may have an idea why smoking will cause lung cancer. There is a kind of biological mechanism behind it. So the goals of this kind of research are two of them. And one is to cure the patient, because if a treatment is really working, you can treat a patient. And the other goal is to prevent the occurrence of a disease or a disease progression. So for example, in the example of the association between lung cancer or smoking and lung cancer, if there may be a campaign to prevent smoking, this may prevent also the occurrence of the disease. So there are 6 steps to carry out and to do etiological research. And the first step is to formulate a hypothesis. The second step is to phrase a research question. Then the third step is to choose a good study design. The fourth step is statistical modeling. The fifth step is reporting results. And the last step is the interpretation of the results. And in this presentation, I will discuss these steps and I will focus on some common pitfalls, so some points of attention. Well, the first step was to formulate a hypothesis. And you can imagine that the hypothesis of an etiological research study should be on a suspected causal risk factors of a disease or other outcome. So indeed, the focus is again on the causal risk factors. And the hypothesis should somehow be placed in context. So it should be placed placed in context. What I mean is that you should read other publication about this subject and see why this study is needed in addition to the other studies already done. And I must say that the study should not be completely innovative. That's not needed. So maybe it is already a good hypothesis if the study was done already in another country and you would like to do it in your own country to see if you find the same association. And indeed, if you do, for instance, a meta-analysis, you will see that people sometimes Well, let's go to step 2, which is phrasing a research question. And a way to help to write a good research question is the PICO format. And that means that a research question should include information about the population, the intervention, the comparison, and an outcome. So to give you an example of a correct research question is, for instance, does delayed versus early kidney replacement therapy initiation affects 20-day survival in critically ill adults with severe acute kidney injury? And here it is clearly written what the intervention or comparison group is, what the outcome is, and in which patients this study will be done. Well, and there is one main common pitfall. And that is that the aim of the etiological research question should not be formulated as a prognostic research question. And to explain this a bit better, I will first tell you a bit more about what etiological research is, and then I will explain you what a prognostic research is. On this table on the left side, I will first show you what etiological research is. And again, I will say that it is understanding about the causal relationship and the biological mechanism. And an example of a research question is, for example, does a higher body mass index increase the risk of chronic kidney disease? And the idea behind this research question, which is an etiological one, is that if a higher body mass index has a causal relationship with the occurrence of chronic kidney disease, then the risk of chronic kidney disease may be reduced by losing weight. Before showing you the right side of the table, I will first give you another example about prognostic research question. And in this example, is about predicting the weather. And people can quite precisely predict the weather, not with one variable, with more variables. Like, for instance, if you know the temperature, if you know it's cloudy, yes or no, if you know if it's windy, yes or no, or more of these kind of variables, you can predict the weather. It is not possible with only one of these variables. If you only know the temperature, it's not enough. Then you can also do it in clinical research. Then we do not predict the weather, but we predict a clinical outcome, like, for instance, mortality or cardiovascular disease. And also these kind of outcomes, you cannot predict it with only one variable, well, sometimes with the exception of age, but usually you need more patient characteristics to predict a clinical outcome. So for instance, you may need age, sex, the presence of diabetes, yes or no, or if a patient is hypertensive, yes or no. So the prediction of an outcome, you should have more variables. Well, let's now go to the right part of the table. And this is an example of a prognostic research question. Again, prognosis is about prediction of a clinical outcome given the specific values of several patient characteristics. And then an example of a research question could be, if we would like to determine a person's chance of chronic kidney disease, should we take the body mass index into account? So you may have already other patient characteristics, and then in addition to that, maybe if you add body mass index to the prediction model, can you then have a better prediction? So this is also the idea behind it. If body mass index predicts chronic kidney disease, people at a high risk of chronic kidney disease may be more easily identified if body mass index is added to the prediction model. So this is only about calculation or identification. So to identify people with a high risk of chronic kidney disease, and it is not about the intention to advise people to reduce weight. That was with the etiological research question. Now I would like to show you two examples from the literature, and together we will see if it is an etiological or prognostic research question. Well, in one of the studies of Galbraith et al. In the American Journal of Kidney Disease in 2005, he wrote in the introduction, body mass index is a well-established risk factor for cardiovascular disease and decline in kidney function in individuals with existing chronic kidney disease. And in fact, in this introduction, the researchers very well explained the potential biological mechanism behind the association between body mass index and chronic kidney disease. So from the introduction, it was quite clear that it was about risk factors and causal associations. So it was clear it is about etiological research. And the research question in this paper was, what is the association between body mass index and the development of chronic kidney disease, independent of its relation with the precursors? Well, the last sentence may be a bit difficult, but it really gives an idea that they want to unravel biological mechanism. That's what the last sentence said. So also from the research question, it's clear that they would like to do an etiological study and they want to unravel causal mechanisms. Now I would like to go to the second example. In this study, they had an abstract, and then the first sentence in the abstract said, to determine factors that are associated with peritoneal dialysis peritonitis. And here it becomes a bit more difficult. They talk about more factors. So maybe they have more risk factors. And for each risk factor, they think about a certain biological mechanism with the outcome. Or maybe it's prognostic research and they would like to predict the outcome. So if you say to determine factors, it's not really clear if it is etiological or prognostic research. So this is a bit unclear. And if you then look at the second sentence, it says, this may facilitate the identification of patients who are at risk. And this seems to be prognostic research because they talk about identification of patients. It looks like prognostic research as it concerns the identification of people. And if we then go to the research question in the paper, it looks a little bit like the first sentence of the abstract. It says, to identify factors that are associated with peritoneal dialysis peritonitis. So again, this could be both etiological or prognostic research if they talk about several factors. And there is no clear biological system or mechanism they talk about. So in this paper, from the introduction and the research question, it's not clear if they do etiological or prognostic research. And also if you read the paper further, it's not really clear what they do because they mix up the two types of research actually. So one of the points of attention when phrasing a research question is that the aim of etiological research should not be formulated as prognostic research, as we just saw. And I should mention that it's not only about the aim, but the difference between etiological and prognostic research is also the statistical modeling, the reporting, and the interpretation of the results. So for instance, the modeling, we will see later on in the presentation that confounding is really important in etiological research to take account of it, while in prognostic research it's not. In prognostic research, you may use receiving operator curves. It's not the case in etiological research. And also the interpretation is really different. In etiological research, you will really also in the interpretation of your result and your discussion, you will talk about the biological mechanism, which should not be the case in prognostic research. Well, this is really a big thing because few authors and also journal reviewers do this right. So it's quite important to know the difference, and that it's important to be very clear in the paper what kind of research people are doing. I would like to move on to step 3, and that's choosing a study design. And Nick Chesney will later on today tell you a lot about the randomized controlled trial. So the only thing I want to say now in this presentation is that it is the preferred study design to examine the causal effect of interventions on an outcome. But although it is the preferred study design, it is not always possible. So for instance, maybe it's not feasible because of costs, but also randomization is often not possible. So if you have people with and without diabetes, you cannot randomize people into a group with and without diabetes because people, they have it or they don't have it. So in many cases, we rely on observational studies. And in these studies, there is no manipulation of the researcher, there's no randomization. So it's just, you see, you just have the data you have. And examples of observational studies are cohort studies and case control studies. Well, I'll already go to the point of attention, and it is because Nick will tell you about the randomized controlled trial, and Kitty already told you a lot about bias. So I go now to the points of attention. And the main point of attention is that the choice of the study design depends on the research aim, as well as on the merits and limitation of the study design. And as I said, the randomized controlled trial could be the best study design, but it's not always possible. But even a case report could be the best study design for a certain situation if, because of a very special patient in your clinic, you have an idea or a hypothesis about a certain biological mechanism between an exposure and an outcome, then even if it's only one patient, a case report could be the ideal study design to let the world know about your hypothesis. So it really depends on the research question, what is the best study design? And then what Kitty already told you is that when you design the study, that is the time you should really think about systematic errors, and also maybe random errors, but especially the systematic errors, because you cannot repair them later on. So in this stage, you can already think about the potential systematic errors and try to avoid them as much as possible. Well, step 4 is about the statistical modeling. And somehow we would like to know the strength of the association between the risk factor and an outcome. And a way to do that is reporting an effect estimate. And usually there are 3 types of regression analysis that report on and that can calculate an effect estimate. And the 3 types are linear regression, logistic regression, and survival analysis. And the choice of the type of regression analysis depends on the type of the outcome. So for instance, is the outcome is continuous variable, like the length of stay in an intensive care unit, then you can choose linear regression. If the outcome is dichotomous, so yes, no, mortality, you're died or you're still alive, then the regression analysis should be logistic regression. And if the type of outcome is the time to an event, so the time to, for instance, mortality, then the regression analysis is survival analysis. And based on the type of regression analysis, you have a type of effect estimate. So for linear regression, it's a beta, for logistic regression, is an odds ratio, and so for survival analysis, is a hazard ratio. And the effect estimates, these give information about the strength between the association between the exposure and the outcome. But then we have something that's called confounding. So when we think we are measuring the effect of an exposure on the outcome, we may actually also measure the effect of another confounding factor. So this factor, the confounding factor, obscures the real effect of an exposure. Well, as an example, we, for instance, looked in the association between body mass index and chronic kidney disease. If we have a kind of extreme situation and the patients with a high body mass index are also the older patients, and the patients with a low body mass index are the younger patients, then the effect of body mass index on the outcome, chronic kidney disease, may not only caused by body mass index, but probably also by the age of the patient. So if all the patients with a higher body mass index are also older, then also the age may have an effect of the occurrence of chronic kidney disease. Well, not each variable can be a confounder, and variables need to satisfy criteria before you can qualify them as confounders. And there are 3 criteria. The first criterion is that the confounder must be associated with the disease. And the second one is that the confounder must be associated with the exposure, which means that it should be unequally distributed between the exposure groups. So in my example, age was unequally distributed because the older patients were also had a higher BMI, and the patients with a lower BMI were the younger patients. It was a very extreme example, but indeed it is unequally distributed. The second criteria, which may be a bit difficult to understand, but we will have some examples later on, is that the confounder must not be an effect of the exposure. It should not be in the causal pathway between the exposure and disease or other outcome. And I explain it a bit more in the following slides. Together we will see if age is a potential confounder in the association between body mass index and chronic kidney disease. To answer this question, you can draw a triangle. So body mass index, chronic kidney disease, and then we will see if age is a confounder. We have to check the 3 criteria. And the first criteria was if age is associated with the outcome. And that is indeed the case because age is indeed associated with chronic kidney disease. The second criterion is if age is associated with body mass index. And that is indeed also the case. So we also fulfill the second criteria for confounding. The third criterion is that it should not be that body mass index has influenced your age, and that will influence your chronic kidney disease. Well, that is not the case, because it's not the case that if you have a higher body mass index, that makes you younger or older. That is not possible. So it's not the case that body mass index will influence your age and that will influence your chronic kidney disease. So age is not an effect of the body mass index. Body mass index does not make you older or younger, and age is therefore not in the causal pathway. And if it's not in the causal pathway, then your criterion is fulfilled. So we can say that age does satisfy the 3 criteria for confounding, and it is a potential confounder in the association between body mass index and chronic kidney disease. And what about sex? The first criterion was if sex will influence, is associated with chronic kidney disease, and that's indeed the case. The second criterion is if it's associated with body mass index. And we think it's also the case. Then the third criterion is does body mass index change your sex? So does body mass index make you a male or a female? And that is not the case. So sex is not in the causal pathway, and therefore again the 3 criteria for confounding are satisfied, and sex does satisfy the 3 criteria for confounding and is a potential confounder in the association between body mass index and chronic kidney disease. We have one further example, and that is if you have a hypertension is a potential confounder. Again, we will look at the first criterion. Is hypertension indeed associated with the outcome? Is hypertension associated with chronic kidney disease? And that seems to be the case. The higher the hypertension, the higher your risk of getting chronic kidney disease. Is hypertension associated with body mass index? I think it's more the other way around. I don't think that hypertension is really, higher hypertension may cause higher body mass index. I said fulfilled, but maybe it's not fulfilled. It's, I think, either not fulfilled. It's probably a bit difficult to say. But actually, if we go to the third criterion, then we could say that body mass index is associated with hypertension, and that may cause chronic kidney disease. So hypertension is in the causal pathway. Body mass index will influence your hypertension, and that may cause chronic kidney disease, which means that the third criterion is not fulfilled, and hypertension is therefore not a potential confounder in the association between body mass index and chronic kidney disease. It's just a kind of causal mechanism how body mass index could be associated with chronic kidney disease. It may go via hypertension. So it's not a confounder, it's in the causal pathway. Well, as points of attention in statistical modeling is that the criteria for confounding must be taken into account, and this is often not the case in studies. So it's really important to do so. Otherwise, you may adjust for variables that are no confounders. The selection of confounders should not be based on a p-value. So that is really data-driven. If you check it in your own database, it's much better to talk with experts or to read the literature to see if the criteria for confounding are satisfied, yes or no. And this is also a very important one. When studying the association of more than one risk factor with the same outcome, then you should check the criteria for confounding for each studied association separately, because the different risk factors may have different confounders. And here it goes often wrong. So sometimes you see a table like this in a paper. And in this table, for example, they have many factors, and age is adjusted for all the other variables in the table. Then the race is adjusted for all the other variables in the table. Diabetes is adjusted for all the other variables in the table. So they didn't think about the criteria for confounding. They just adjusted the analysis for all the other variables in the table. And it could be correct, but usually it's not, because usually you have different confounders for the different relationship between exposure and outcome. And then this is a quite difficult one. The last one is that the adjustment for mediators, in our case it was hypertension, it could be correct, but only to unravel a biological mechanism. And I will explain it a little bit more later on in my presentation. Then you could have a different effect estimate, for example, males and females. And if there is a different effect estimate, then it may be really misleading to present only or to present the overall effect estimate. Because if it's different for males and females, there is no overall estimate because you are always a male or a female. So it's good to check if there may be different effect estimates for different subgroups. And if so, you can better present the effect estimate for the different subgroups. And then again, one should not use statistical methods that are related to prognostic research, as I said earlier. And this also happens, well, quite a lot. We move on to step 5, and that's the reporting of results. We again are interested in the association between body mass index and chronic kidney disease. In this case, the effect estimates are hazard ratio with a 95% confidence interval. And on the left side, you see model 1, the unadjusted model, which means there is no correction for confounders. The effect estimate is 1.07, and this means that with each 1 kilogram squared meter higher body mass index, people are 7% more likely to develop chronic kidney disease. What you also see here is a 95 confidence interval, and this means that if we repeat the study many times, then in 95% of the repeating, 95% of the cases, the hazard ratio will be between 1.03 and 1.10. So in almost all cases, the chance is very high, 95% chance the hazard ratio will be above the 1. And this means that there is a statistically significant effect if the 95% confidence interval are both above the 1 in this case. The 95 confidence interval also says something about how precise your effect estimate is. If the confidence interval is wide, so it should be, for instance, between 1.03 and 3.90, it's wider, then your effect estimate is less precise instead that the confidence interval is smaller. I also show you here a model 2, and this model was adjusted for age and sex because we already saw that these were potential confounders in the relationship between body mass index and chronic kidney disease. And then we find a hazard ratio of 1.05, which means that with each 1 kilogram squared higher body mass index, people are 5% more likely to develop chronic kidney disease. So you see a difference between the unadjusted model, the effect estimate, and the effect estimate of the adjusted model. So indeed, age and sex did confound the association a bit in the unadjusted model. There was also a third model because also smoking at baseline and history of myocardial infarction seems to be confounders. And if you correct also for this, the hazard ratio decreased to 1.04. Well, in this study, and this is probably a bit complicated, but they also adjusted for a mediator. Well, usually this is really not the case. Usually you only correct for confounders because confounders should satisfy the criteria of confounding. The only reason to additionally adjust for a mediator is to unravel the mechanism to see how much of the association go via hypertension. So if one would like to adjust for a mediator, it should be really clear in the research aim that this should be done. And also in the method section and throughout the paper, it should be clear why you adjusted for a mediator. So to explain again, the adjustment for a mediator is done because one may want to unravel a biological mechanism to examine to what extent the association between the exposure and the outcome is explained by hypertension. Well, if you do that, you additionally adjust for a mediator. In this case, the hazard ratio decreased from 1.04 to 1.02, when we conclude then that half of the effect of body mass index and chronic kidney disease is explained by hypertension. So it's really to unravel a biological mechanism. So the point of attention when reporting results is to report the effect estimate. Oh, you should only report the effect estimate and not of the confounders, because you're interested in the association between your exposure and outcome, and you would like to eliminate the effect of the confounders. You're not interested in the effect estimate of the confounders. You're only interested in the effect estimate of your exposure in relation to your outcome. As we just saw, it's important to report both the unadjusted and the adjusted estimates, because then you can see to what extent the variables confound the relationship between the exposure and outcome. We also saw that it's important to report a 95% confidence interval. And it's important to report both the absolute and the relative risk. And I showed you today only the relative risks, but sometimes the relative risk could be really high and impressive. But if you then look at the absolute risk, that's maybe quite low. So that's why it is important to report both, because they're really related to each other. And only if you have both the absolute and relative risk, you can formulate a valid conclusion of your study. Well, you may know that there are checklists like the Strobe and Consort checklist, and these may help to report your study methods and results because they clearly describe what you should report in your paper. Well, this brings me to step 6, the last step, and that's the interpretation of the results. We already discussed it before, but if you do an etiological study, it's important to discuss the potential biological mechanism also in the discussion, of course, in relation to the results you found in the study. And if you would like to formulate a valid conclusion, then you should also think about the possible limitation of the study. You can, for instance, think about residual confounding, which means that you may not be able to correct for all potential confounders because probably you did not measure them or you don't know them. Maybe there are unknown confounders. So if you don't know them, you can also not measure them. As Kitty also said, also to formulate a valid conclusion, one should think about the bias. Although you may not be able to repair it, you can at least describe your bias and think what kind of influence it could have on the conclusion of your study. And also think of things like lack of statistical power must be taken into account for a valid conclusion. So what we did today is describe all the steps. I focused on some main points of attention, but not all of them, as this was not possible. I think for step 2, one of the most important messages was that there is a difference between etiological and prognostic research, and that sometimes people mix them up, not only in the research question, but also in the statistical modeling and the reporting and interpretation of the results. In step 4, we really talked about the concept of confounding and thought about it. And I also explained that in some cases it is allowed to correct for a mediator, but that's a very different purpose. That's only to unravel the biological mechanism behind the association. In the reporting of results, we talked about that there are different types of effect estimates, and that if you report the unadjusted and adjusted result, you can see to what extent the confounders are had an influence on your association between an exposure and an outcome. That were, I think, the main points of attention. But I did not, as I said before, discuss all the points of attention. We recently published a paper on this subject. It's still EPUB, so in nephrology in 2021. And this paper discusses almost all points of attention when conducting etiological research. And it includes a table which summarizes all the points of attention. I think this was it. Thank you very much for your attention. If you have any questions, I'm happy to answer them, and thank you very much.
Thank you very much, Vianda, for your conference, your excellent conference. For all the panelists, I want to remember that you can choose the language of the translation at the bottom of the screen on the right. Todos pueden elegir el idioma de la traducción en la parte inferior de la pantalla a la derecha. No, tengo solo una pregunta que hace el doctor Loza Munarriz, es how to handle or interpret intermediate or surrogated variables in an etiological research. For example, high cytokine levels in COVID-19 are related to a severe inflammatory reaction to the virus. Different reactions to other viruses. Therefore, can you guide us to relate a possible etiology?
Yeah, thank you for this question. This is a really good question. And I think we can even give a talk, a separate talk about surrogate outcomes. And I cannot say in general if a surrogate outcome is a good one or not, because that really depends on each association you would like to study. But in general, you could say that a surrogate outcome, you should try to see to what extent this is related to the real outcome you would like to measure, but somehow it's not possible to measure. Maybe it's too hard to measure the real outcome, or you have to wait too long for the real outcome. There are reasons why you use a surrogate outcome. But if the surrogate outcome is not really related to the real outcome, you may have a wrong association, let's say, between the exposure and your surrogate outcome. Maybe you think about a biological mechanism that's related to the real outcome, but if your surrogate outcome is not really related to your real outcome, you may go to wrong conclusions. So this is really difficult, but sometimes it's also a solution to choose a surrogate outcome, because maybe it is a good one or a better one, and you have maybe it helps you better to formulate a hypothesis between a biological mechanism between your exposure and outcome. So it could help, but I think we should also always be, you could get not a good association. I hope I'm clear enough, but it's a really good question.
Okay, thank you very much. Is there any question? Okay, we have a break now, and we are very late. For people from ERA-EDTA, there are 7 hours later than for us, so that we have to maintain the program strictly. Now we are going to have the break, and we are meeting, we will meet again in 20 minutes. Okay? Bueno, continuamos ahora con la conferencia del doctor Chesnaye. Doctor Chesnaye, bienvenido.
Retomamos con la presentación Intention to Treat and Pair Protocol Analysis in Clinical Trials con Nick Chesney de Netherlands.
Yes, and thank you for this introductory slide. And I'd also like to thank the organizers for the opportunity to present today. Let me just share my screen. I must warn you, they are building a house next door to me right now, so I hope it doesn't interrupt us too much during this presentation. So, good afternoon or good morning. We do have a 5-hour time difference. My name is Nick Chesney and I work as an epidemiologist for the ERA-EDTA registry based in Amsterdam. And during the next 30 or so minutes, I hope to walk you through the two most used methods of analyzing clinical trial data, called the intent to treat analysis and the per protocol method. Can you all hear me well enough? Is the sound good? I'll assume so.
Yes, it is perfect.
Okay, good, thank you. So before we dive into the methods, I'd first just like to go over the basics. So I'm sure you're all very familiar with these terms. Randomized controlled trial, or RCT. So we consider this the gold standard when we wish to investigate the efficacy or effectiveness of an intervention. And I must mention that the intervention here can be, it doesn't necessarily have to be a new experimental drug, but it could also be something like a new surgery or even a physical fitness training program, for instance. But if it is a medicinal intervention, so a new drug, RCTs also give us the opportunity to assess the safety of these new medications, as well as the efficacy or effectiveness. And there is a difference between those two words, but I'll come to that later. So an RCT has a few characteristics. It is always prospective, because we do follow patients longitudinally, so over time, into the future. It is comparative, because we always compare at least one intervention group with a control group or a placebo group. It could also be multiple intervention groups we'll be comparing, but for the sake of simplicity in this presentation, I'll stick to just one intervention group versus one control group. And RCTs are quantitative, because what we basically do when we follow these patients over time, we count the outcomes. So we measure outcomes in both groups and compare them at the end of the trial. And of course, RCTs are randomized. So looking at this schematic here at the bottom, on the left here, you can see our sample. So this is something that Professor Kitty Jager talked about. So we sample this from the population that we're interested in. After we have our sample, we can randomize them. So we can randomly allocate this population into two groups using a random process to the intervention group and the control group. We can follow these patients over time. And at the end of the study or during the study, we can measure outcomes in both groups. So why do we bother randomizing in these trials? Well, first of all, randomization ensures that each patient has an equal chance of receiving the intervention because it's a roll of the dice. And this means that on average, that both groups will be hopefully comparable, as due to this random process, it will balance known and unknown prognostic factors in both groups. So with prognostic factors, we mean factors that may affect the probability of the outcome occurring. So in other words, after randomization, these groups are balanced, and the only way that they differ is with regards to the intervention being applied. Of course, it doesn't guarantee that these groups are completely equal and completely balanced. They may also always be subtle differences, but then we can always say that these differences are only due to chance. Another important reason for randomization is that we avoid confounding by indication. This was mentioned previously, but you can imagine a physician seeing a certain patient saying, well, you're very sick, you have an indication for this or that type of medication, and these patients are prescribed that medication. So this means that the patients that receive the medication are inherently different from those that don't receive the medication. They may be more or less likely to encounter the outcome during follow-up, which would make the groups again very different. So this is a very important reason why we randomize. And below here in the schematic, we can see in this pool of subjects here a very diverse population represented by all these different shadings. And after the random process, we hope that in both the experimental or intervention group, the distribution of certain characteristics such as age or sex are the same in the experimental group as in the control group. So let's start with the perfect situation. We have our sample population. We randomize them by throwing the dice, and we have a 1-to-1 ratio, randomization ratio. So half the patients get assigned to the intervention and the other half assigned to the placebo or control group. This control group could also be the standard of care, depending on the question or the medicine we're experimenting on. We follow up these patients over time, and at the end of the study, we can say, well, in this group, 25% encountered the outcome, and the same was in the control group. Now, in the perfect situation, all patients randomized will take their medications as instructed. These are all very good patients. They come to every visit and they complete the study without any fuss. So this is perfect. However, as you all know, in reality, the perfect RCT doesn't exist and things don't always go as planned. So during follow-up, some patients may be lost to follow-up. They might decide to move to a different country. And this means that for this certain patient in the intervention group, we weren't able to collect any data on the outcome. So this is missing for this patient. In other situations, it may be that a patient has certain side effects and has to stop taking the medication and then receives the standard of care and therefore may be placed in the control group. So again, we lose a patient in the intervention group and we gain a patient in the control group. So this is also a difficult situation analysis-wise. Again, there may be patients that have mild side effects and they say, oh, I'm not going to take my medication today, and they miss a few doses of their medication. We call these patients non-compliant. And in other cases, it may be that the side effects are so severe that the patient just drops out of the study completely. Again, we're missing outcome data for this patient. So these types of circumstances or situations are known as protocol violations or protocol deviations. So these are mostly stated in the protocol for the randomized controlled trial, the rule book for a trial. So as we've seen, patients can drop out prematurely, being lost to follow-up in some cases, or maybe just withdrawn from the study due to severe side effects. And in this circumstance, we'll be missing outcome data on these patients. Other patients will not take the medication as instructed, so these are non-compliant patients. And this is also a difficult case because, well, the patients aren't taking their medication, so they aren't exposed to the intervention that we're interested in. In another case, it could be that patients were randomized to take the experimental drug, but were, due to side effects, had to be treated using the standard of care. So in other words, will be placed in the control group. So they'll basically be switching groups during follow-up. Another one is, for instance, that the physician decides to prescribe a different type of medication or an additional medication that also affects the primary endpoints of the outcome we are studying, which will also influence the results for this patient, and other smaller ones, such as missing a study visit. So the question is, how do we deal with this type of participant or protocol violations? How do we analyze the data after we've collected it? Well, I'd just like to walk through a few examples or a few options. So in this case, we have our control group again with 4 patients. The red one here has encountered the outcome. And we also have the intervention group here with 4 patients, of which 1 encountered the outcome. Now, in this example here, there is a protocol violation of this patient. He or she is non-compliant, so stops taking the medication and has to switch group and eventually receives the standard of care, which in this case is the same as the control group. So how do we analyze this type of patient? Well, there are 3 main options. There is the per protocol analysis option. We can say, well, this patient didn't take his medication according to protocol. This data is corrupted. We're going to just throw this patient out of the study. That's the first option. The second option is, well, he or she wasn't really treated with the interventional or experimental drug and was placed under the standards of care. So we might as well analyze it as a control patient because it was treated as such. And this type of analysis is called as treated. And in the third case, we can say, well, we prescribed this interventional, this experimental drug to this patient. It was randomized to the intervention. We had the intention of treating this patient with the new drug. We are going to analyze this as the intention to treat and keep this patient in the intervention group. So those are the 3 main options, but I'll be focusing on the per protocol and the intention to treat options for the rest of this presentation. So the choice we have between these 3 options also affects our results. So if we were to analyze per protocol, so the first option by throwing this patient out of the study, and we were to, our outcome was based on the number of good outcomes, we could say in the control group, we have 3 out of 4 patients have the good outcomes at 75%, but because we threw out that 1 patient who had a bad outcome per protocol in the intervention group, we have 3 out of 3 patients with a good outcome, meaning 100%. If we were to do it as treated, well, in this case, we placed this patient with the protocol violation into the control group, meaning that there are 2 out of 5 or 3 out of 5 in this case with a good outcome, or 60%, and there are still 3 patients left in the intervention group with a good outcome, so again 100%. So the intention to treat analysis, we have 3 out of 4 patients because we kept this patient in the group, giving us 75% of good outcome, as we did in the control group. So this is just to illustrate that depending on the analysis technique or method you choose, this does affect the results that we can attain. So let's just go over the intention to treat, what it actually means. Intention to treat, we also often say once randomized, always analyzed. So this means that patients are always analyzed according to the groups to which they originally randomized or originally assigned to, even if they underwent various protocol deviations or violations. So this type of analysis typically tries to answer what is the effectiveness of assignment to the intervention. So what is the effect if a physician was to prescribe this drug to a patient in the future? What would be the effect of prescribing it? And the bigger advantage of the intention to treat analysis is that it really reflects the daily clinical practice, because in real life, of course, there will also be patients that are prescribed a drug but don't end up taking it because they don't feel like it, or they have side effects and they have to withdraw. So this really reflects what happens in real life. And importantly, it also preserves the prognostic balance of randomization. So we're not mixing up the groups, we're just keeping them as they are. So the balance that we have with regards to the unknown prognostic factors remains the same between the intervention group and the control group. And as we're not throwing any patients out of the study, we're also able to maintain our sample size, which is also important because we do our power calculations beforehand. We want to try and maintain this sample size. So how do we analyze intention to treat? We're just going over a quick example here. So in the intervention group, we have here a patient who completed the study without any protocol violation. This is our second patient here, and somewhere towards the end of the study, he or she encountered the outcome, given here by the red lightning. The third patient that was randomized to the intervention group was lost to follow-up somewhere early on. And this fourth patient is a bit of a strange patient because halfway through, he or she got side effects and had to switch over to the standard of care group, or the control group in this case, and then encountered the outcome whilst being treated with the standard of care placebo, or not placebo in this case, but the control group medication. And in the control group, that we have 4 patients randomized. These 2 patients completed follow-up. This one encountered the outcome, and the last one, unfortunately, again, was lost to follow-up. So in the intention to treat analysis, we analyzed as we randomized these patients. So these top 4 patients here will keep everybody in the group, even the ones that have the protocol deviations, so the ones lost to follow-up. And this last patient here, even though the outcome occurred whilst this patient was taking the same medication as the control group, this outcome here will still count towards the outcomes counted in the intervention group. So that's an important thing to keep in mind when with the intention to treat analysis. So this, we'll see later on how this causes a dilution of effect, and why the intention to treat analysis is deemed conservative, a conservative approach of analysis. So we also have the per protocol analysis. The per protocol analysis, as we've mentioned before, excludes patients who had any type of deviation from the protocol. And this tries to answer the question, what is the efficacy of patients if they are fully compliant? So it's really measuring the effect of exposure to the medication and really reflects the efficacy. So any kind of biological mechanisms that this medication will be causing to deal with the disease it was designed to deal with. So it really measures the effect of actually receiving a treatment throughout follow-up. So how do we handle this same group of patients if we were to analyze per protocol? Well, we simply remove the patients that underwent encountered any protocol violations. Now, as you can see, this substantially changes the groups that we have here. And of course, this is one of the main issues with the per protocol analysis, that excluding patients that had protocol deviations changes the characteristics of the groups and increases the risk of attrition bias. So if we exclude patients, there is the danger that these groups no longer have similar characteristics, and therefore we are basically violating the principle of randomization, because these groups now look very different as compared to what they first were. So just to give an example here, when we randomize these patients, as you can see on the right-hand side here, this was a perfect randomization because half of the patients in each group were men and the other half of women. So we have a perfect balance with regards to the sex distribution in both groups. But if we were to do a per protocol analysis of these patients, we would be removing these ones. And now if we look at an intervention group, it only exists out of men, whereas the control group has 2/3 women. So this makes comparisons perhaps very difficult, because men generally have very different clinical characteristics as compared to women, depending on the disease studied. Another example is age. When randomized, we had a perfect balance between the control group and the intervention group, with both groups having a mean age of 50 years old. Well, when we exclude the patients per protocol, this changes, of course, the age distribution in our groups. And if you look at the intervention group here, we only have 2 very young patients left in the group with a mean age of 22.5. And in the control group, we have a mean age of 60. So again, these groups aren't really, it wouldn't be very fair to compare these groups anymore. So another issue is that this attrition bias, related to attrition bias, is that this non-compliance could be related to the intervention and or the disease severity. So it could be that specifically the patients with a severe disease or poor health status can't tolerate the side effects of the drug being tested, and that these patients specifically, so the very unhealthy ones, are forced out of the intervention group because of these side effects, whereas the somewhat healthier patients, they can tolerate these side effects very well, and they can stay in the group. So this is basically a selection bias that occurs during follow-up, and in this case, it would cause a decrease in the outcome to be measured in the intervention group. And if these very sick patients cross over into the control group, we would see an increase in the outcome in the control group. So in this specific case, that would lead to an overestimation of the treatment effect. So this is just a short example of how attrition bias can really affect the results of the study. And of course, the last disadvantage of a protocol analysis is that if a lot of patients violated the protocol, that would mean that a lot of patients would have to be excluded, and this can reduce the sample size and power for our analysis. So I'd just like to briefly go over a few of the study designs that we frequently come across in randomized controlled trials. The most common one is the superiority study design, in which we wish to establish that, let's say, treatment A is superior or better, it works better than treatment B. And looking at this graph here, this is our point estimate for the difference in effect between the groups A and B. And this dotted line here is the threshold we have set beforehand. And we say, well, the difference in efficacy between these two treatments has to be more than this threshold if we want to establish, if we want to say this drug is superior than the treatment B. In this case, it wasn't, so we can't say the superiority was achieved in this trial. Then we have the equivalence studies. So these studies aim to establish therapeutic equivalence between two drugs. So this could be the case if, for instance, there is a generic medication brought to market and we want to compare it to the original patented medication, and we want to say, well, this new generic, somewhat cheaper medication is equivalent to the very expensive patented medication. We might decide to do an equivalence study answering the question, trying to establish that drug A is not unacceptably different compared to drug B. And then lastly, we have the non-inferiority studies, which are somewhat similar to equivalent studies. But in this case, we're saying drug A is not unacceptably worse compared to drug B. An example could be, for instance, if our new drug has the same mechanism of effect, but it has less side effects, then we want to say, well, we want to just test to see if the efficacy isn't inferior to what's already on market. So how does our choice of analysis method affect the interpretation of the results for each of these RCT study designs? Well, I'm just going to divide them into two. So first we'll look into the superiority design. Well, as we've seen, the intent to treat, we analyze patients as they were assigned to their groups. So it ignores non-compliance, so it ignores patients that didn't take their medication, and it ignores crossover. So it ignores patients that went over to the control group. So because of this, the difference in outcome between these two groups will actually become smaller. Because, well, for instance, non-compliance, the exposure to a certain medication will be a lot less. So if there was any effect of this medication, it's going to be smaller. And this will be seen in the difference between the groups with regards to the outcome. So for that reason, the intent to treat is considered a conservative analysis method. And therefore, when using a superiority design, it's less likely to accept a new treatment as effective. But it is still the method of the standard method of choice when analyzing superiority RCTs. And the protocol analysis is often added as a secondary supporting analysis. However, when looking at equivalence or non-inferiority studies, again, we see the same concepts apply here. So intends to treat, ignores non-compliance, crossover, and for that reason, the difference between arms will be smaller. But in this case, this is exactly what we're trying to show in an equivalence or non-inferiority study. So that's why this is deemed optimistic. So we're more likely to accept equivalence or non-inferiority because of this attenuation between arms difference. So the recommendations say that the per-protocol approach needs to show concordant results with the intent to treat results. And this is also given by two important organizations that make guidelines for RCTs. So the first one states in a non-inferiority trial, both the intent to treat and the per-protocol analysis have equal importance, and that their results should lead to similar conclusions for a robust interpretation. And similarly, the consort guidelines also strongly recommend that we provide both intent to treat and the per-protocol analysis, and that these have to provide identical conclusions to be able to say that these studies results we can be confident in these study results. So I'd just like to finish the this talk by going over a few examples. This is one from the Women's Health Initiative. So this study looked at the effect of estrogen plus progestin hormone therapy versus placebo on breast cancer. The intent to treat analysis showed that a hazard ratio of 1.25, meaning that the intervention group had a 25% higher risk of breast cancer compared to the control group, placebo in this case, and a per protocol analysis was actually a lot higher, finding a 68% increased risk of the intervention group versus the placebo group. But it must be noted that only 60% of the participants were still receiving the assigned treatment at 6 years. So a lot of these patients withdrew from the study or just stopped taking the medication. So in this case, the intent to treat really reflects both the hormone therapy, but also the incomplete adherence, whereas the per protocol analysis really reflects the actual exposure to the hormone therapy, giving a much higher risk of breast cancer. So the effect of the received treatment in this case was twice as high as that of the assigned treatment. And for that reason, we believe that it's important to provide women not with only the intent to treat analysis results, but also that of the per protocol. And that is also the reason why these two types of analysis are very complementary to each other. They provide different types of information that really help patients and physicians decide on whether or not to prescribe or take a medication. So the second example is the ASPIRE trial. This is in a population of patients with relapsed multiple myeloma, looking into progression-free survival. We have an intervention of carfilzomib and a control group of lenalidomide and dexamethasone. So the original idea was to assign these almost 800 patients and follow them up over 4 years. However, the intervention group had to stop after 1.5 years after enrollment, whereas the idea was to follow them up for 4 years. So they only took the medication for the first 1.5 years. And the other 2.5 years, they were receiving exactly the same medication as the control group. So if we look at the intent to treat analysis, looking at the entire study period, we found they found a hazard ratio of 0.69 or a 31% reduction in the risk of or protective effect for progression-free survival. And the per protocol analysis was even more protective. But again, they looked here at the patients at 18 months. So they're looking at the patients here that actually took the medication and comparing this in both groups. So they concluded that this secondary per protocol analysis really shows that the protective effects for progression-free survival of this intervention medication was actually underestimated in the intent to treat analysis. But lastly, I'd just like to go over the EXCITE trial. So this is a multi-center RCT on the effect of a home exercise program on physical performance in dialysis patients. I'd like to focus on their secondary outcomes, the hospital admissions specifically. So at randomization, they had 151 patients in the intervention group and 145 in the control group. But interestingly, looking at the per protocol population, so these are just the patients that were actually able to complete the home exercise program, we see that only 69% of these patients were left in the per protocol population, whereas the control group did somewhat better with 85%. So this just goes to, you can see here already that a lot of patients weren't able or didn't want to complete this home exercise program, although a 69% uptake, I guess, can be considered relatively high. So let's look at the results here. So this is the cumulative instance of hospitalization in the intent to treat group. They didn't find a significant difference. They did show a slight reduction in the risk of hospitalization in those that were in the intervention group. But after looking at the per protocol results, so these are the patients that actually completed their home training program, they did find a borderline significance, or they found a significant effect with the active arm here having more than half, less than half the risk of hospitalization compared to the control arm. So the authors do conclude, but very carefully, that the analysis of hospitalizations in patients who completed the trial was of borderline significance, suggesting a beneficial effect of exercise on hospitalization. So suggesting potential, they're very careful here, and not without reason, because it is very difficult to distinguish whether this effect is actually due to them actually completing the program, so actual exposure to the fitness program, but it could also be due to the selection of only those patients that were healthy enough and strong enough to actually be able to complete this physical fitness program. So this is an important point. This is also the attrition bias we were talking earlier about. It could be just a selection of the healthiest, stronger patients, which of course have a lower risk of hospitalization. So in summary, the intensity to treat analysis really tries to answer the question, what is the effect of assigning a drug to a group of patients, and really reflects the daily clinical practice. It maintains randomization, and for these reasons, it's the standard of analysis of clinical trials. Whereas the per protocol analysis really tries to answer what is the effect of receiving a drug, so real true exposure to a drug in a group of patients. However, there are dangers, as we've seen with attrition bias. The groups may no longer have similar characteristics. But as stated by the Coord guidelines, both types of analysis should be reported for all planned outcomes, because they do provide complementary information. So I'd just like to say that this most of the slides and information here is from an article that we published early last year in Nephrology. It's free to download, so if you're looking for more information on these concepts, please have a read. Well, thank you for your attention, and I'll be happy to answer any questions you may have.
Many thanks for your wonderful presentation, Dr. Chesneye. Let's go to the question and answer time. We have 10 minutes to the answer, and then before the Dr. Massey conference, we'll have another time longer for the question and answers. The first question is from Dr. Dario Jimenez. He's asking about if we can do an RCT study with a historic cohort as a control group.
If we can do the analysis intensity to treat and per protocol, in a study of registry patients? Well, it is possible to do intensity to treat analysis and per protocol analysis in observational data. Of course, we can't randomize patients, but for instance, if you wanted to compare survival in registry data, in the ERA registry data, looking at survival in hemodialysis as an intervention group versus peritoneal dialysis as a control group, you could say that the intensity to treat analysis would view patients that started their treatment on either of these modalities as the intended treatments, disregarding any switches in dialysis modality, and just looking at the outcomes at, let's say, after 5 years. Whereas in a per protocol analysis, you would censor them basically at the first time that they switch treatment. So if they switch from hemodialysis to peritoneal dialysis, you could say, even if there isn't really a protocol, you can say, well, this is a protocol violation, and we will handle this by censoring the patient or removing the patient completely from the analysis.
Thank you, Dr. Exusnaye. Dr. Alejandro Ferreiro, that is the president of SLAN, and Dr. Oscar Novoa, the president of the Congress, are between the participants of the course. Dr. Ferreiro has congratulated you for your excellent conference and asked about sometimes many randomization is impossible for reasons of design, economics, opportunity, etc. How close are propensity match studies to the benefits of an RCT study?
That's a very good question. And of course, the randomized control trial is the golden standard, but it is not always.
Dr. Please put the mic near your mouth because, okay. Yes,
Sorry.
yes, okay.
Yeah, so it's a very good question. So the RCT is considered the golden standard, but of course, randomization isn't always ethical. We can't randomize, for instance, hemodialysis patients to or peritoneal dialysis. So then we're left with observational research. And this is, of course, very important, and the reasons, one of the reasons that the registry exists. How close can we get to a randomized control trial using propensity score matching? Unfortunately, not very close. Propensity scores are just an additional way to adjust for confounding, and only for known confounders, so only stuff that we've already measured. So that's the biggest difference with adjustments for variables that are known and randomization. Randomization also makes the groups comparable with regards to the unknowns or unmeasured confounders. And we can't do that with observational research. We will always have the issue of unmeasured confounders, and it doesn't matter if we use propensity scores, matching, or inverse probability weighting, or just simple correction for confounders in a regression model. We will always have to have the issue of unmeasured confounding.
Thank you. Dr. Laura Solá is asking about, she said that it's very interesting that in some occasions, sometimes it's more it's of better utility the PP analysis than the ITT, as in the case of extortions. But what should be the decision of take into account one or another analysis?
Well, as said during the presentation, the one is not better than the other. There isn't one that we have to choose as the truth, because they both answer very different questions. The intention to treat analysis really answers the question, what is for a doctor, for instance, what is the effect of prescribing a medication? So if you see a patient and you want to prescribe a medication, then the intention to treat effect estimate will give you a more realistic view of what will happen, because it reflects the clinical reality. There are patients that will stop taking the medication, and the protocol analysis really looks into what is the effect of receiving, so the actual exposure, the mechanism of how this drug will actually work, and answers the question, what is the effect of receiving a medication? So they're two very different questions, and that's why both estimates are complementary to each other. They both give more information.
Thank you. Dr. Weisinger, Beisinger is asking about when you plan a study, you need to calculate beforehand the number of patients to be included in order to have enough subjects to have an intention to treat analysis. I don't understand if this is a question, Dr. Beisinger. Sorry, we have another question of Dr. Jimenez about the historic cohort that he has asked previously. He's asking, he said, for example, if I have a new treatment and I want to compare its efficiency in a prospective study, but the control group consists of historical patients who had no option to the new treatment. He's commenting his previous question, I think. Okay, there's no any questions, I think. So we are going to let Dr. Massi to start this conference. Thank you very much, Dr. Chesnay. Now, welcome, Dr. Massi, and you can start your presentation.
Damos cierre esta mañana con la presentación Validation of the Predictive Value of Biomarkers con Siad Massi de Francia.
Dr. Massi, you are mute. Are you mute?
Yes, I'm sorry.
Okay.
I'm just back to you hear me now? Did you hear me?
Yes.
Yes, thank you.
Hear you.
I just saying I wish it to be with you and live, but COVID was stronger than us, so we should have it virtual. I would like to discuss with you how to validate of predictive value of any biomarker. And I am head of the Department of Nephrology in Paris, co-director of INSERM unit, and I, until a few days ago, that was chair of the registry, ERA-EDTA registry. What is the definition of biomarker? This is a working group of NIH in 1998. They defined the biological biomarker as measured, evaluated indicator of normal biological process, pathogenic process, pharmacological answer to any therapeutic intervention. The NIH working group decided that it will not limit this biomarker to the blood or other bodily fluids, but include other measurements such as blood pressure, heart rate, or any other biomarker For example, you can use the intima media thickness of the artery, carotid artery, score of the calcification, dimensions of ventricle in the heart. What you should know, especially for any fluid like blood, you need really to have a good mode of blood drawing. You need to also decide when you take this biomarker, in the morning fasting situation. You need to be sure that transport and storage doesn't lead to instability of the sample. Sorry, and more important point that we need to have a standardized assay. And this assay could look for the mother molecule precursor or some active form. And what we discuss today is validity of this assay, and to be sure that this is give you the right value of any biomarker. What is the validity? The traditional way to define the validity, that it means that get the correct result, is sensitivity and specificity. Sensitivity means correctly classify cases, and specificity correctly classify known cases. How to calculate this sensitivity and specificity? You have a table, and you have a positive test, negative test, disease present, and disease absent. And you can have a column and line row to analyze. Let's start by sensitivity, which means that you have a positive in disease. The calculation takes this column. A disease is present. You have A, which is a true positive, and C is false negative. And then you have the ratio of A, true positive, against A plus C, true positives and false negatives. It's total one. This is mean if you have the sensitivity 100%, this is all the test positive give you presence of the disease. This probability being test positive when disease is present. If we go to specificity, which is negative in health, you take this column. And here, and you can have a negative test with disease absent in D. And then you have a formula like a D, which is true negative, divided by B and D, which is a total true negative and false positive. So specificity gives you the probability to be test negative when the disease is absent. So sensitivity is positive when the disease is present. Specificity is negative when the disease is absent. We can have additional item to evaluate the validity. One of them is positive predictive value, PPV. Then when we have take the line here, and we have divide test positive when disease is present is true positive against the total. And this is probability patient having disease when the test is positive. And we can have the negative predictive value. You take this line, and same when you have test negative and disease absent, and divided the total. And then you have the patient not having disease when test is negative. Once you have this predictive value, you need to progress by calibration and discrimination. This is automatically the steps when you do for validation. I will take the example well known for all of you to share with you how to progress in these two steps. As you know, the Framingham risk calculators, which include age, gender, blood pressure, lipoprotein, glycemia, smoking, diabetes, and recently they add left ventricular hypertrophy and antihypertensive treatment and arterial fibrillation. Just allow you to assess 10-year risk of coronary heart disease and stroke in general population. And I'll show you later on what happened for chronic kidney disease patient, which certainly need, in addition to this Framingham risk calculator, additional biomarker. Let's start with calibration. This is mean that we can have the formula and we will calculate the probability by this event by Framingham calculator. And then you follow this patient and the study, and you need to compare what the formula predicts against what we really observe during the follow-up. And you can have a test to comparing predicted and observed number of events called Husmer-Lemshow test. If it is no significant, this is mean you have no difference between predicted and observed, this you have a good calibration. If they are different, then you have a poor calibration. An example of Framingham study, this is what we follow, the estimation of 10-year risk of coronary heart disease. This is what formula predict in one study, and this is what we observe. And then you can see there were no big difference between a predicted and observed one. If you look, put it in the figure like that, and you can see identity line is also linear, and the test was non-significant. So once you calibrate, you need to discriminate. And this one, and the discrimination going by the estimated probability by the calculator. And you need to know whether this calculation give you the discrimination ability, and we use a ROC curve analysis to do that. All of you are familiar with ROC curve, and which usually it's should be higher than 0.5. It's very significant when they are more than 0.8, and then you have a good discrimination performance. Here, how to design this ROC curve, and you have the sensitivity and 1 minus specificity, and you have this curve ROC. And then you see here the area under the curve represents 0.78 and they're highly significant. This is mean that this biomarker, whatever they are, is really discriminated biomarker for the event. ROC curve or C statistic has been standard metric for this quantifying over many decades. However, there are some authors which done several studies to analyze the limitation of this metric. For example, lack of clinical relevance, the difficulty to interpretation for small magnitude of change, for example, the place of HDL and Framingham risk score. And then there are proposition for new test called net reclassification improvement, NRI, which is attempt to quantify how well a new model reclassify subject, and if it is appropriate or inappropriate comparing to old model. The validation could follow, and once you done your test by calibration and discrimination, you need to confirm by additional cohort. One of them in internal validation. This is mean you can split your total cohort in 2 parts. For example, 2/3 of the cohort you want to follow this biomarker, what we call development or discovery. curve and cohort, and then you have what we call validation cohort to confirm. If by chance your cohort is very low, and then to have a random chance to see result which is not true, you can go what we call repeated measurement, what we call bootstrap, which mean or tenfold cross validation for that. You can follow this internal validation, but we call temporal validation. This is mean that you follow the patient during the follow-up, and you see if this new case, new incident patient of this cohort confirm your validation. The best, the gold, and this is important for any paper published for the biomarker, is external validation. This is mean you need to take your results and to have a different cohort, different country, different hospital, different unit to confirm whether or not what you see initially in your discovery cohort, even if you validate it by internal validation and temporal validation, is also true in different populations. I would like to show you a few examples to how to progress in this validation in our patient, and show you the difficulty we have in CKD patient to have this validation markers. As you know, if you, every one of us agree that CKD increase the risk, and this is the incidence rate of coronary heart disease, stroke, and heart failure, comparing the non-CKD. This is even adjusted for all the traditional risk factor you see down here. We did a few years ago the comparison between in the cohort on CKD stage 3 to 4, and we follow them and we look about fatal and non-fatal myocardial infarction. We use Framingham-Anderson formula to predict, and then you have this formula, and you can see that the formula can give you a slightly increase of prediction for fatal and non-fatal myocardial infarction. Really slight, because when you did the root curve, which was represented only 40% of area under the curve. So it's traditional risk factor Framingham, it's work in our population, possibly because several cardiovascular risk in our population is related to atheromatosis, but this is only explain only 40%, 30 to 40%. The example of lipid is clear to show you that difference between general population and our population. If you look what happened if you use hypolipemic agents, often statin or statin with ezetimibe, and if you decrease LDL cholesterol by 1 millimolar, in general population, this is a meta-analysis for 21 trial, you expect to have 25% risk reduction. However, the 3 study in our population, Aurora 4D, which were non-significant study, the primary outcome was non-significant. In Sharp study, it was significant. You can see that this percentage is really low, meaning that, yes, we could have a part of the risk, the lipid as a predictive in our population, but this prediction is less than we observe in general population. So what happened if we add a new marker to ameliorate this prediction? And then at that time in 2005, we look for one marker of inflammation, fibrinogen, and we see that the high level of fibrinogen predict more coronary heart disease than low level of fibrinogen. And when we did it on multivariable analysis, and you can see the fibrinogen was a significant one to predict this one. And then we back to the curve, ROC curve, and we add fibrinogen, and we slightly ameliorate this Framingham risk factor, not too much. Other did the same and with more patient, and either for chronic kidney disease or non-chronic kidney disease, but we focus today on chronic kidney disease. This is traditional risk factor in gray, and traditional risk factor with other factors like albumin, hemoglobin, coagulation factor. And you can see there are no amelioration of prediction in our patient. So after KDIGO prepare the risk factor for mortality and cardiovascular complication and progression of renal disease to renal failure, it was clear that decrease of GFR is also a risk factor to increase the risk, for example, of mortality or cardiovascular complication, as well as the increased concentration of proteinuria. When this has been tested in overall big study in kidney disease, you can see that eGFR, albumin creatinine ratio, and or both predict very well cardiovascular mortality, coronary heart disease, heart failure, and stroke. And I will give you the importance of adding albuminuria and eGFR to ameliorate the prediction. This is coming for diabetes patient. UCAP PDS have, for example, similar that Framingham risk factor. And you can see that also here explaining only a few, the area under the curve is around 30%. If you add with the Swedish evaluation, the albuminuria, or if you go to Steno Danish risk engine, adding albuminuria and eGFR, you can see that we have an amelioration of prediction. So clearly, the traditional risk factor is important in this patient, but we need to add as an additional risk factor like albuminuria and eGFR to ameliorate this prediction. It is more complicated in our patient. This is hemodialysis patient. This is what we have here, Framingham, confirming always that's a slow prediction. And if you take Brisbane score, when they add previous cardio event, duration of dialysis, body mass index, and phosphate. Body mass index is related to insulin resistance. And you can see how better the prediction. And this study, there were no validation, external validation of the cohort. So we remains without any confirmation. But again, this is a new independent marker like insulin resistance and phosphate, which could ameliorate the prediction. Calcification, score of calcification has been proposed as one of this new marker to predict. We had a study following patients with stage 2, 3, 4, and 5 in dialysis. And we look in different score, coronary calcification score, radiography score, and also abdominal aortic CT scan score. And we can see that in all of them, there are progression of calcification when the eGFR decrease in this patient. And there were no difference about all of them were significant with the progression of kidney disease. And in this study, we look for antimamedia thickness and other parameters of vascular evaluation. And when we look about this net recalcification and proven NRI, and we find that the best biomarker is coronary artery calcification, which ameliorates significantly the prediction in addition to traditional risk factor like age, gender, diabetes, smoking, lipid, and smoking. So yes, then we have an additional biomarker in addition to phosphate. For example, coronary artery calcification could be, and this study, neither intima media thickening or other vascular tests did not have any effect in amelioration of the prediction. And large study have been done also in general population. You can see in CKD, coronary artery calcification was also significant amelioration of NRI, while the other intima media thickness or other vascular evaluation would not significant. And this is also even true in non-CKD patients. So yes, in our patient, the traditional risk factor explain only part of the risk. We need to work hard to find an additional one. One of them could be intima media, insulin resistance, phosphate or vascular calcification. I hope I show you today how to progress in the validation of any biomarker and difficulty we have in chronic kidney disease patient to ameliorate the prediction of cardiovascular risk. Thank you very much. I'm open for your question.
Wonderful, Dr. Masih. Thank you very much. We have some questions in the chat. Dr. Cesar Loza is asking about what is the impact of sample size on internal validation techniques. Is it valid to perform internal validation with any of the predictive models, such as logistic regression, linear regression, Poisson regression, and Cox regression?
I think a good question. Thank you. The size is very important. More patients you have in your cohort, which can divide it in development, discovery one, and internal validation, it's important. Then you can confirm your result. And for any test you want to check, if you want to have only case control or follow-up, you can do it. But certainly, the bigger size is very important to have internal validation. However, I should say it's internal validation is not confirmation of the quality of the biomarker. You need to go to external validation, because the internal validation, your patient, even they are separated in two parts, they are still following the same way, following the same, they have same risk, they are living in same area. So you need to have a different validation in different area, different technique, and different strategy.
Is there any more question? Please, this is a moment to ask the teachers. So
it's.
I think there is no more question for you.
Fine. Yeah. Thank you.
Could you please tell us something to before say goodbye?
you asked me to say something. I'm really glad always become in South America and Latin America, and usually I used to go once or 2 times a year, and to be there. And usually after this meeting, we did have time to go have some caipirinha, cachaça, but now it's this is my second meeting, virtual meeting with people from the registry, Kitty, Vianda, and Nick by virtual. I hope next year will be nicer and we have a chance to be in live in South America. Thank you very much. And we are, I'm sorry, just one additional work. The ERA-EDTA is very happy to support the work in South America, and Carlota did you know that, and we have a good relationship, and we are happy, and Kitty running this very well. So thank you again for this. Let us present this meeting, and I think Kitty could say also additional word.
Thank you, Ziad. Well, I just wanted to say thank you very much for your hospitality. We have had a great time. I hope that that this course has been of any educational value for you. And thank you again, and hope to see you in the future face to face.
Vianda and Nick, want to tell something to us?
Yeah, thank you so much for the invitation, and yeah, it was better to see you live. That's for sure. We were so much looking forward to it because we already met your team, I think 2 years ago, and we were planning to go to your congress. But anyway, I really hope that we had a good time, and we even strengthened our collaboration, which is very important. Thank you so much.
Not the snow this time, not BA, but Nick?
Yes, I can only repeat what my colleagues have already said. Thank you very much for having us, and I hope next time we can do it live in person. And as Ziad said, have a few cocktails afterwards. That would be amazing. Thank you.
Okay. Dr. Alejandro Ferreiro is thanking you for your collaboration again. And Dr. Ziad, I promise that next time will be cachaça or wine. I don't know what, but we'll have.
Whatever you want will be with you. It's nice people and nice company, so it's no problem.
Okay, I want to thank you again for your warm and kind collaboration, and until the next time.
Yeah, I would like to thank 158 participants to stay with us and asking good questions. So thank you again. Really enjoy to be there.
Okay, thank you very much. Bye-bye.
Bye-bye.